My name is Dr. Ashok Kumar. I am Professor and Head Department of Medicine, Santosh Medical College, Santosh deemed to be University, Ghaziabad. Today I am going to speak on very important topic which is relevant to each and every diabetics. That is, the topic is hypoglycemia. Hypoglycemia may be documented by Whipple's triad, in which there are three components are there. The person should be having symptoms which are consistent with hypoglycemia. There should be evidence of low plasma glucose concentration measured with a precise method by either by glucometer or blood investigation, and relief of symptom after the plasma glucose level is raised. So this constitutes a Whipple's triad in which there should be a symptom should be there, and there is evidence of blood glucose level, and if we supplement or treat the patient with glucose dextrose, the patient should be relieved of his or her symptoms. There are a number of causes of hypoglycemia in adult, like drugs, which is some person is on drugs like insulin or insulin secretagogues, person is taking alcohol, or person is having ill with critical illness like hepatic, renal or cardiac, or person who is in sepsis or in aneation, that is not able to take any feed. There are certain hormones which are also related to the development of hypoglycemia, that is deficiency of cortisol, growth hormone, glucagon and epinephrine in insulin deficient diabetes. Sometimes some non-islet tumor may also be the cause of hypoglycemia. In seemingly well individual, there are causes like endogenous hyperinsulinism, in which there is more secretion of insulin is there, like in cases of insulinoma or functional beta cell disorders, or insulin autoimmune hypoglycemia can be there, in which there is formation of auto antibody to insulin, or there is formation of antibody to insulin receptor. And there are certain disorder of gluconeogenesis and fatty oxidation may lead to hypoglycemia, and strenuous exercise or long standing exercise without taking any meals may lead to hypoglycemia. Sometimes hypoglycemia occur due to accidental or surreptitious or malicious hypoglycemia, in which there is either person is took insulin in the higher doses, or some person accidentally take OHA which is present nearby, which is running to one of his or her parents or siblings. Whenever there is hypoglycemia, body shows some counter regulation. That is, the counter regulation means the mechanism that normally prevent or rapidly correct hypoglycemia. Whenever there is decreased arterial glucose is there, this gives stimulation to our pancreas or brain. What does the pancreas do? There is a decrease in the insulin secretion, or there is increase in glucagon, which leads to the effect on liver, causing decreased gluconeogenesis or increased glycogenolysis, which causing increased glucose production by the liver. And also a decreased arterial glucose stimulate the brain, which causes increased sympathoadrenal outflow, and also give stimulus to pituitary. Due to increased sympathoadrenal outflow, there is a stimulation of adrenal medulla, which leads to the more formation of epinephrine or norepinephrine, or increased acetylcholine, which causes glycogenolysis through the liver, or decreased glucose absorption through the kidney, and also there is increased gluconeogenesis by muscle or by fat. All these things leads to increased production of glucose, leading to correction of hypoglycemia. And through the stimulation through the brain, if it goes to the pituitary, there is increase of growth hormone or release of cortisol through the adrenal cortex, leading to increase glucose production. Whenever there is a hypoglycemia is there at certain level, various level of hypoglycemia produce various symptoms. At the level of glycemic threshold 80 to 85, there is the response is decreased insulin, secretion, which causes increased reappearance of insulin, and there is increased lipolysis, increased free fatty acid or increased glycerol. So it is a primary glucose regulatory factor which is a first defense agar hypoglycemia is there. So it causes decreased insulin causes rate of glucose appearance is increased. At the level of 65 to 70 there is a increased glucagon production from the pancreas which also causes rate of glucose appearance is increased. It is also a primary glucose counter regulatory hormone. At the level of 65 to 75 milligram of glucose, there is increased epinephrine or increased cortisol hormone and growth hormone. So these are the third defense against the hypoglycemia, and they are become critical when the glucagon is deficient, and when the levels are around 50 to 55 milligram percent, the symptoms occurred, and there is a person may be recognized something is happening to me, and they may recognize as a feature of hypoglycemia. So the person may develop if he thinks that symptoms occurs, the patient may think that he or she might be developed hypoglycemia. So they can correct themselves by ingestion of sweeteners or food ingestion. And when the level become less than 50, these affect the cognition effect, and it compromise all the behavioral effect which can compensate or which can be tackled hypoglycemia. So when the 90 milligram, if it is the normal blood glucose level, at the level of 70 counter regulatory hormone release occurs. At the level of 60 milligram, adrenal symptoms appears. At the level of 50, neuroglycopenic symptoms occur. Around 40, if the levels are 40 milligram, the patient may develop into lethargy. In the level, if the level is 30 milligram percent, then patient may develop coma, and at the level of 20 milligram, patient may throw seizure, and when the level is around 10 milligram percent or less, the patient may develop permanent neurological damage because of the persistent hypoglycemia. Hypoglycemia in diabetes is a limiting factor in the glycemic management of diabetic mellitus because it causes recurrent morbidity and sometimes fatal. It precludes maintenance of euglycemia, leading to complication in long run, and it started a vicious cycle of recurrent hypoglycemia by producing hypoglycemia associated autonomic failure. Diabetics suffer an average of 2 episodes of symptomatic hypoglycemia per week, and at least 1 episode of severe, at least temporarily disabling hypoglycemia each year. An estimated 6 to 10% of people with type 1 diabetes die as a result of hypoglycemia. So now you can understand the person may die because of the development of hypoglycemia in type 1 patient also. So that's why it is a very serious complication in management of diabetes. The incidence of hypoglycemia is lower in type 2 diabetes mellitus than in type 1 diabetes mellitus. However, its prevalence in insulin requiring type 2 DM is surprisingly high, and recent studies have revealed a hypoglycemia prevalence approaching 70%. Development of hypoglycemia confers a presence of various conventional risk factors like if the doses of insulin or insulin secretagogue or OHA are excessive, ill-timed, or of the wrong type. If the influx of exogenous glucose is reduced, it means the patient or person has not taken sufficient meal as per the doses of OHA or insulin. If the insulin independent glucose utilization is increased, as in the scenario of excessive exercise or during exercise, and if the sensitivity to insulin is increased by some or other measures with improved glycemic control, or in the middle of the night, late after exercise, or with increased fitness or weight loss. Also, when there is endogenous glucose production is reduced, that is in cases if the person is taking alcohol, then it causes decreased glucose production by the liver, or in cases of insulin clearance is reduced, as in cases of renal failure, because insulin is secreted mainly by kidney. If the kidney is damaged, the insulin will be remain for longer time in the body, which may has its effect leading to hypoglycemia. Few words regarding hypoglycemia associated autonomic failure. The concept of hypoglycemia associated autonomic failure in diabetic put forward as a fact that recent antecedent iatrogenic hypoglycemia during sleep or exercise causes both defective glucose counter regulation by reducing epinephrine response to a given level of subsequent hypoglycemia in the setting of absent insulin or glucagon response and hypoglycemia awareness. So there are defect whenever these hypoglycemia associated autonomic failure occurs. There are defective glucose counter regulation and development of hypoglycemia unawareness is there. These impaired responses create a vicious cycle of recurrent iatrogenic hypoglycemia, hypoglycemia unawareness, and to some extent the reduced epinephrine component of defective glucose counter regulation are reversible as by as little as 2-3 weeks of scrupulous avoidance of hypoglycemia in most affected patients. Additional risk factor for hypoglycemia in diabetics: there are absolute insulin deficiency, a history of severe hypoglycemia or hypoglycemia unawareness implying recent antecedent hypoglycemia, and impaired renal function. As we all know, the long-term complication of diabetes is development of diabetic nephropathy or in long-term ESRD. So, if the person develops impaired renal function, they maybe have additional risk factor to develop hypoglycemia. Classical diabetic autonomic neuropathy is also a risk factor, and lower HbA1c or lower glycemic goals even at elevated HbA1c level, if they are there, then hypoglycemia may be there. Now coming to the classical symptoms of hypoglycemia. The symptoms can be divided into two, like neurogenic, or we can say autonomic, or neuroglycopenic. In neurogenic or autonomic symptoms, their patient may have developed trembling, palpitation, excessive sweating, anxiety or palpitation, or hunger, or develop severe nausea in the neurogenic symptoms. In neuroglycopenic symptoms, patient developed a difficulty in concentrating at various works. He may develop confusion. He may develop drowsiness to the various responses. There may be some certain visual changes, and speech may become slurred and may develop dizziness. So these are the neuroglycopenic symptoms of hypoglycemia. Hypoglycemia further classified into the level 1, level 2 and level 3. In the level 1, when there is measurable glucose concentration is less than 70 but it is more than 54 milligram per dl. In the level 2, blood glucose concentration is less than 54 because it is the threshold at which neuroglycopenic symptom occurs and requires immediate attention. Then it becomes a level 2. In the level 3, the severe event characterized by altered mental status or physical functioning that requires assistance. The blood glucose level at this are not defined, but any level of hypoglycemia or any level of blood glucose that requires that develop altered mental sensorium, then patient require immediate assistance, though it is a level 3 of hypoglycemia. Now coming to the management of hypoglycemia. If the patient is able, it is the management of hypoglycemia depends on the presentation of the patient, whether the patient is a patient is in his senses or not. If the patient is able and willing, the oral treatment with glucose tablet or glucose containing fluid, candy or food is appropriate. A reasonable initial dose is 15 to 20 grams of glucose can be given to the patient if the patient develops hypoglycemic symptoms, and if he is willing or if he or she can take the food or substance, glucose containing substance, then definitely it should be given to as early as possible to mitigate the symptom of hypoglycemia. Parenteral therapy is necessary with severe symptoms or person who cannot take the oral glucose. Then in that cases we have to administer IV glucose 25 gram followed by glucose infusion guided by serial plasma blood glucose measurements. If the IV therapy is not practical, then we have to give subcutaneous or intramuscular glucagon, which stimulating immediate glycogenolysis, and doses can be 1 milligram in adult or 0.5 milligram in children can be used, particularly in patient with type 1 diabetes mellitus. Glucagon is ineffective in glycogen depleted individual. This concept should be remembered with and should be always be remembered, because in glycogen depleted individual, that means those with alcohol induced hypoglycemia, the glucagon is ineffective, because glucagon causes glycogenolysis from the liver. If the glycogen storage is not there, then glucagon is not going to be correct the hypoglycemia. Glucagon also stimulates insulin secretion and is therefore less useful in type 2 diabetes mellitus. The somatostatin analog octreotide can be used to suppress insulin secretion in sulfonylurea induced hypoglycemia. These treatments raise plasma glucose concentration very transiently, and patients should therefore be urged to eat as early as possible to replete the glycogen storage in the body. So, as we have already discussed, the management of hypoglycemia depends on the patient's condition. If the patient is well aware and conscious or able to take the glucose, he or she should be given oral glucose containing substance. If the patient is having some certain neuroglycopenic symptoms or in altered sensorium, then definitely IV treatment with the glucose followed by serial measurements of blood glucose level should be done. Or sometime we can use intramuscular or subcutaneous glucagon injection to produce glycogenolysis. And we have to, in alcohol, person who develop alcohol induced hypoglycemia, it should be avoided, because there are no glycogen stored in the alcoholic individual, because of there is no substrate for glucagon to become active. So that's why it is ineffective in the alcohol induced hypoglycemia. After the treatment, we have to also emphasize on the hypoglycemia risk factor reduction. Several recent multi-center randomized controlled trials investigating the potential benefit of tight glucose control in either inpatient or outpatient setting have reported a high prevalence of severe hypoglycemia, like NICE sugar study, advanced accord, veteran affairs diabetic trial. Surprisingly, all three studies found little or no benefit of intensive glucose control to reduce macrovascular event. Therefore, in-hospital glycemic maintenance goal have been modified to lie in between 140 to 180 milligram per dl, so that severe hypoglycemic event should not be occur in this patient. Multi-center trial have demonstrated that individuals with recently diagnosed type 1 diabetes or type 2 diabetes can have better glycemic control with less hypoglycemia. And reasonable therapeutic goal is the lowest HbA1c level that doesn't cause severe hypoglycemia and that preserve awareness of hypoglycemia. It should be our goal. So we have to have lower HbA1c goal and with lower risk of hypoglycemia. That should be our goal while treating the patient with diabetes mellitus. And patient should be aware of regarding these symptoms. To prevent the recurrent hypoglycemia requires the understanding of hypoglycemia mechanism. Offending drug can be discontinued or their doses should be reduced. Self-monitoring of blood glucose is an essential tool in prevention. More the patient do the blood glucose, self-glucose monitoring, more he will be aware regarding development of hypoglycemia at various level of blood glucose level. Real-time continuous glucose monitoring appears to be a useful tool for decreasing time spent in hypoglycemic range in people with impaired awareness. And we have to definitely underlying critical illness management has to be done, like management of hepatic, renal or cardiac illness in proper manner, so that hypoglycemia should be prevented. With this, I conclude my topic of hypoglycemia. Thank you very much for patient hearing.